Good afternoon and welcome to Science Says. It's terrific to have everyone here with us this afternoon. We've got some really fantastic panelists, and we're going to be talking a lot about some of the new advances in cancer, and both from a research standpoint and a cancer treatment standpoint. I want to start off by thanking our presenting sponsor, which is Microsoft. Microsoft and its employees fuel extraordinary impact, both here in Washington State and around the globe. They're our partner on a variety of projects to improve cancer care, and we're proud that so many in the Microsoft community have done so much for the Fred Hutch in terms of supporting us on Obliteride, on year-round gifts, on other ways of supporting the Hutch. It's been terrific, and congratulations for our Microsoft colleagues who today in Europe received approval for their incorporation of Activation Blizzard into their family of companies. So congratulations to Microsoft for that. So today we're going to talk about the treatments for cancer. What's happening in cancer? What are the new things that people are working on? What are some of the new exciting technologies that are out there? And you're going to hear about ideas that could become part of clinical practice in the next few months or the next couple of years, and some that might be further off, either in terms of screening tests or actual treatments that we're doing now. The three panelists that you will meet today are all MD PhDs, meaning they have a PhD and went to graduate school for anywhere between 4 and 6 years to get a PhD, and they also went to medical school, and then they did full training on top of that. So this is an extraordinary group of researchers. They are also great examples of the relationship between the University of Washington and the Fred Hutch, in that they are both faculty members at the University of Washington and faculty members at the Fred Hutch, and hold appointments at both institutions, and showing the way that we can work together to improve outcomes for cancer patients and their families. They have a great perspective on where we are, and I think you're going to really enjoy the conversation. So first, I would like to introduce our first panelist. Our first panelist is Dr. Petros Grivas. Petros is a medical oncologist, an educator, a mentor, an innovator, and a researcher who takes care of patients with genitourinary cancers. And for those of you who don't do this all day, a genitourinary cancer could include bladder cancer, prostate cancer, testicular cancer. But Petros's main research interest, and the way we think of him, is as a bladder cancer expert. But he also knows a lot about all those other types of genitourinary cancers. If there are questions about prostate, renal, testicular, please don't hesitate to ask those as well, because Petros is quite well versed in that. His clinical research and leadership have been absolutely essential. When we think about impact, we think about the 3 Ps. Things that change paradigms scientifically, things that change practice, and things that change policy. And Petros's career, he's done all of those in terms of thinking about how we take care of patients with bladder cancer. And Petros, welcome. And I understand you are joining us today from Greece. And right now in Greece, it is probably close to, maybe it's about 9 o'clock at night, 10 o'clock at night.
Tom, you're correct. Great to join you. It's actually about 10 p.m. here, and I'm very excited to talk to you. I'm here to mentor students representing, our global oncology identity from Fred Hutch. I'm very excited about it, and thanks for inviting me.
So I guess the first question that I'm going to have for you is, you've recently changed some practice standards in bladder cancer, and we know there's about 80,000 new cases of bladder cancer a year. Can you talk more about this? And I want you to specifically, I want to ask specifically about the idea of local bladder cancer and more advanced bladder cancer, because I know there's some bladder cancers that people are able to get taken care of by the urologists, and they go in and maybe do some local treatments. There's others that require people like you, Petros, to get involved. So tell us a little bit about bladder cancer and what the spectrum of disease is like.
Absolutely, Tom. I hope my connectivity remains good and you can hear me okay. It's really important to know that bladder cancer is actually one of the most common cancers globally. And we think about healthcare disparities. It's an important problem to tackle globally. It's the most expensive cancer to treat. from diagnosis to death on a per patient basis, there has been a stagnancy with not major developments for almost 3 decades, but things are changing now, and are changing for many reasons. Number one, amazing researchers around the world are coming together, and Hutch is, I think, leading the way. We have a multidisciplinary team, urologists, medical oncologists, radiation oncologists, pathologists, and radiologists. We have a multidisciplinary clinic where we see patients with localized disease. And of course, we have a plethora of clinical trials where we try to implement novel ideas and transform the treatment landscape, as you mentioned. We have a number of examples how our recent clinical trials change the landscape, paradigm, practice, and policy, as you said, in a global level. And I'm happy to talk to you a little bit more about those examples.
So Petros, I guess the first question is, what's the most common symptom of bladder cancer? Is it blood in the urine? Is it pain? What is it?
Blood in the urine is the most common symptom of bladder cancer. And actually, we just had our bladder cancer walk in Seattle, one of the biggest walks in the country, to raise awareness about how important and common bladder cancer is and what the impact it has is in the community. And blood in the urine is the most common symptom. And sometimes, Tom, we see delays in diagnosis, especially in women, because it's misunderstood for urinary tract infection or kidney stone. So it's vital, to your point, to not ignore the symptoms and get right to the urologist for a proper workup and timely diagnosis.
And so again, when we think about, so let's say you have blood in the urine, and the urologist can do a simple scope, put a scope into the urethra, look in the bladder itself, and look into the bladder wall and see what's there. And if they see a lesion, how do you know if it's local bladder cancer, which can be easily taken care of with just removing it from the wall of the bladder and maybe some treatment afterwards, versus more serious or muscle invasive bladder cancer? How does the urologist know that?
Absolutely, and the urologists are the forefront of diagnostic evaluation. They're doing cystoscopy, going inside the bladder with a camera, looking around, evaluating for tumors. They may get a biopsy, or they go to the operating room to do what we call a scraping, removing the bladder from the tumor from the bladder wall. And also they look to see if there are any other lesions in the area of the bladder, because sometimes it's not only one tumor. We may have more than one tumors. We do also CAT scans. We do CAT scan of the chest and the abdomen and pelvis to look for potential metastases. And depending on the proper staging, that includes an exam, under anesthesia, a proper histology evaluation by pathologists from the scraping of the tumor of the bladder, and the CAT scans, we have the proper staging. And through our multidisciplinary clinic that we have at UW Fred Hutch, we try to tailor the treatment paradigm for this particular patients based on patient characteristics and, of course, tumor characteristics in as much individualized way.
And so, Petros, one of the things I remember from my practice in oncology is the relationship between smoking and bladder cancer. How important is smoking cessation, and how related are cigarettes and bladder cancer?
Absolutely. Great point, Tom. Smoking is the most common and appreciated risk factor for bladder cancer development, across with a plethora of other cancers as well. There is a significantly higher risk of bladder cancer in patients with people who have history of smoking. Of course, quitting smoking is very, very important, but we have to, of course, keep an eye on the patients over time. And this is also in addition to other environmental factors, sometimes metals, arsenic, painting materials, printing materials, and different other chemicals in factories. Firefighters may have higher risk, hairdressers because of hair dyes, machinists, and all of those represent risk factors, in addition to genetic factors and maybe prior radiation on certain forms of chemotherapy. All may play a role, but smoking is by far the most important risk factors, and the policy to try to reduce smoking globally has a major impact to prevent bladder cancer.
And Petros, I know an area that you've been a national, and actually an international leader in, is in the application of immune therapies for bladder cancer. Now, we've known for quite some time that the immune system is important in treating bladder cancer. And one of the things that was discovered years ago is if you go in with a cystoscope or a camera inside the bladder and you see a localized lesion, take it off. Sometimes they would put in something called BCG, which could cause a local immune reaction, which could prevent other cancers from forming there. But you've taken it many steps forward now, and we have specific T cell stimulating and engaging molecules that help to activate an immune response. Tell us a little bit about immunotherapy and bladder cancer and some of the things you've done that's made a huge difference for patients.
Absolutely. And Tom, you're correct. The most established form of immunotherapy, the older form of immunotherapy in oncology, is this intra-bladder, intravesical installation of this form called BCG, an attenuated form of the bacillus that was related to tuberculosis. And we saw back in the 70s that actually this has significant effectiveness in reducing the chance of cancer coming back, recurrence, and progression to a higher stage for what we used to call superficial bladder cancer. And this was a very, very important milestone. Now, years later, we have modern form of immunotherapies that can be administered intravenously through the vein, and especially in patients who have muscle-invasive or metastatic bladder cancer. Now we have a lot of data supporting the use of checkpoint inhibitors. Checkpoint inhibitors are a modern form of immunotherapy that takes away the checkpoint, the break of the immune system. So one example, Tom, of our work and that changed the way we treat metastatic bladder cancer across the world, we look at patients who had metastatic bladder cancer, and we usually treat these patients with chemotherapy. After the end of chemotherapy, we used to watch these patients closely until the cancer grew back again. And usually this happens soon after, because even if you have a benefit, this was short-lived. What we saw, and we published this in a major journal, we actually showed that immunotherapy given in sequence after the end of chemotherapy make people live much longer, who had a significant survival, as we call it, benefit, and longer time until progression that generates significant improvement, of course, if you think about quality of life of those patients and longer life. And now this has been the sequence and the standard way we treat these patients with metastatic bladder cancer. We give immunotherapy after chemotherapy if the cancer has not grown to chemotherapy. So we're moving forward, of course, to expand upon these great findings and the new standard of care.
And so, Petros, question I would have is surgery still the only thing that people can do who've got bladder cancer that's muscle invasive, or can they get by with chemotherapy and radiation and maybe save the bladder in that setting?
Great question, Tom. And that's another example of the beauty of our multidisciplinary bladder cancer clinic. We have a radiation oncologist, colleagues that Ramesh will talk after me. His colleagues are there. We have surgical urologists. We have pathologists, radiologists, and we all together look at the films along with medical oncologists like me, and we try to see in this particular patient, based on the location of the tumor, the histology characteristics, other symptoms that the patient may have, other features that the tumor may have, is bladder preservation an option? And I can share with you, Tom, that about 20% of our patients, 1 out of 5 patients, may be able to keep their bladder even if they have muscle-invasive tumors. And we use a maximum reduction with removal of the tumor endoscopically, this scraping we discussed before, and this is followed by concurrent chemotherapy and radiation. And in those patients who are good candidates for this approach, we have great results. And now we're doing a large phase 3 clinical trial, Tom, to evaluate whether the addition of immunotherapy in the backbone of chemotherapy and radiation makes a difference. And that trial is ongoing. Hopefully we'll have the results in the near future. And this is an exciting option and a potential opportunity for our patients.
Terrific. So, Petros, you are going to come back in about 20 minutes or so. We're going to have you come back for the panel discussion. And we want people to think about bringing their questions about bladder and certainly prostate and kidney and testicular as well. Happy to have some questions in that area. And Petros, what I want you thinking about is what do we need to do next to get us to the next place in bladder cancer? And we'll talk about that when you come back in 20 minutes. It's really great to have you. So thanks for joining us from Greece tonight. See you in a bit. So next, I would like to introduce my colleague, Dr. Ramesh Rangan. Dr. Rangan is a radiation oncologist at the Fred Hutch, and he is chair of the Department of Radiation Oncology at University of Washington, where he's the Peter Rudin Professor of Radiation Oncology. He also leads our radiation oncology division here at the Fred Hutch. So it's delightful that Ramesh is with us. Ramesh's primary clinical focus is caring for patients with lung cancer and melanoma, As a researcher, he is interested in how radiation can enhance the immune system. You heard a little bit of that from Dr. Petros Gribas, who talked about that important role in that area. And Ramesh, it is really terrific to have you with us. Now, I know you and I like to talk about this a lot. You always point out to me, Tom, that radiation oncology at UW and Fred Hutch, we're one of the only places in the world that have all of the particles that you can use in radiation. Tell us a little bit what that means. What does it mean to have all of the particles?
Thank you, Tom. And I also want to echo your gratitude to everyone who has joined us today. My gosh, what a wonderful turnout. And I want to thank you all for your continuing support of the mission at the Hutch and UW Medicine. So what does it mean when we say all of the particles? Well, when we talk about radiation treatment, traditionally, what we're usually referring to is X-rays. And if anybody's ever gotten a chest X-ray, they know what X-rays are all about. They pass in one side and go out the other, and they're very good at not only producing images of our internal organs and internal anatomy, they're also, right at the same time that X-rays were discovered for diagnostic purposes, they were started to be used for therapeutic purposes. They're very effective at sterilizing cancers. But over time, we've recognized that X-rays aren't the only form of radiation that can benefit our patients. There are other types of radiation. Proton beam radiation, which we have in our arsenal, has some benefits in that because it's a particle, it can penetrate, but sort of like calibrating a weapon of precision that stops where you want it to stop, like an exploding bullet. A proton can pass into the patient and then stop at the tumor, and that's where it does most of its damage. And so for a subset of patients, not everyone, that is beneficial. We've also recognized from the very early days of cancer research that one of the markers of bad behavior from a cancer is poor oxygenation, hypoxia. So if there's very little oxygen within the tumor, we know that that tumor is a bad actor. And those tumors are very hard to sterilize because protons and X-rays actually need oxygen to help do the damage to the DNA to sterilize the tumor. Well, one solution to that is to use a different particle, neutrons. Neutrons are not so reliant upon oxygen. So when we are confronted with those tumors that are more hypoxic, that we need a different weapon to treat, for that subset of patients, neutrons are a fantastic weapon to be able to treat those patients. So again, when we talk about precision radiation oncology and precision oncology, no one size fits everyone, but it's important to have all of the tools so you can pick the right tool for the right patient.
And so, Ramesh, I was at the American Association of Cancer Research meetings just recently, and there was a tremendous amount of excitement about something called flash radiation oncology, flash radiation therapy. And tell us a little bit about that and what you think the promise of that new technology could be.
Sure, I'm happy to. It turns out that in some ways, one of my favorite tennis players of all time is Stefan Edberg. I know you're a tennis fan, and years ago he was asked, hey, what's the secret to winning all these Grand Slam tournaments? And he said, well, tennis is a really simple game. It's just a matter of hitting the ball to where your opponent isn't. Now, that was obviously tennis is much more complex than that, but that simple statement belies conveys the notion around what a tennis champion is trying to achieve, getting the ball to where the opponent isn't. Well, as a radiation oncologist, my job is to get the radiation to only the tumor and not touch anything that isn't tumor. And it turns out that if you deliver radiation at dose rates at a rate that's much higher than the doses that we conventionally use in the clinic today, 10,000 times higher than the rate that we're using right now. When we deliver a standard dose of radiation, it is delivered over minutes, sometimes over 5 to 10 minutes. This is delivering an entire course of radiation in a few milliseconds. When you do that, it appears that the radiation is essentially invisible to the normal tissue. It passes right through the normal tissue, but it is still just as impactful to the tumor. There's something different about the way a tumor reacts to radiation that retains its sensitivity to radiation even when it's given at these super high dose rates, which we refer to as flash dose rates. And again, we're very fortunate here. We are one of the few programs in the world that has a full bench to bedside arsenal to interrogate this flash effect in patients. So in order to really bring this to the clinic, we have to do real careful preclinical research. And we have a preclinical platform to investigate flash dose rates in models of cancer so that we can then translate and identify the subset of patients who would best benefit from this approach.
So I guess one of the questions I would then have is if flash has less toxicity to normal tissue or causes less damage to normal tissue, does that mean that with flash you can get a much higher biologically effective dose into the tumors? So, when we think about what kind of dose you can get into a prostate cancer or a breast cancer, it would be fantastic to be able to give more dose to the tumor and spare normal tissue. So has flash helped that promise? Is there enough evidence to know that yet?
Yeah, we're not quite there yet, but that is definitely the road that we're on. One of my mentors in research used to constantly remind me that there's no such thing as absolute resistance to radiation, meaning if you give a high enough dose of radiation, you can sterilize any tumor. And so, in theory, if we can give infinite dose to a tumor and zero dose to the surrounding tissue, there is no tumor that we couldn't completely eradicate. And what flash does is gets us one step closer to that reality, and it's not true for every bit of normal tissue that our body has, but for many of the normal tissues that are most sensitive to radiation, such as the bowel and the skin, it appears that when we deliver this ultra-high dose rate, those tissues seem to not even react to the radiation in the same way as they would with standard dose. And that allows us to give a much higher dose to the tumor.
And so, Ramesh, if you think about it, a tumor or radiation has such an important role, like rectal cancer, okay? And there you talk about you've got a normal colon and rectal mucosa, which is very sensitive to radiation. And if you could give a higher dose of the cancer and not cause terrible side effects from the bowel, that would be terrific. Have you started using this yet in patients, or is this still experimental?
This is still experimental. There have been 2 trials that have just started to report on whether this is safe, because one of the challenges when you're delivering a full course of radiation in a millisecond, you have to be ultra precise in terms of calculating the dose and being sure that you're giving exactly the right dose, because even if you're off by a few nanoseconds, that can significantly increase the amount of dose that you're delivering. So it requires real careful studies, and that's why we're fortunate to have a world-class physics team to help us along here, to help us really ensure that we know exactly what we're doing when we bring this to the clinic. Now, having said that, there is a fair amount of interest and enthusiasm because the secret about radiation treatment that many people don't realize is that the doses that we use in the clinic are not dictated by how much dose we believe is required to get rid of the tumor. It is dictated by how much the healthy tissue around the tumor can tolerate. So if we can get past thinking about our dosing based on how much the body can tolerate and more based on how much we need to get in to get rid of the tumor, which is what the flash phenomenon might get us closer to, then that's only going to be to the benefit of our patients.
Ramesh, thank you so much. We're going to have you back during the Q&A in just a second. We've already had a bunch of questions come in about radiation, so we look forward to more of that. So thank you, Ramesh. Really terrific to have you today. So next, I'd like to bring in Dr. Min Fang. Min is a Fred Hutch researcher and director of the Cytogenetics and Genomics Division at the University of Washington. She studies how changes in DNA can lead to cancer. In particular, she identifies cancer-causing chromosomal abnormalities in patient cells, which are critical to diagnosing and guiding treatment. And she's working with a team at Google to develop an artificial intelligence algorithm that could transform this labor-intensive process into an automated one that takes just minutes or seconds instead of hours and sometimes a full day to read a karyotype. Welcome, Min. It is fantastic to have you with us. And can you share an overview of what you do and how it's done today?
Sure. Yeah, it's such a pleasure to join this activity, and it's wonderful to see so many attendees. Thank you to be here. Yeah, we, as Tom just mentioned, we do look for any changes in DNA and DNA modifications that could lead to cancer. And so in our daily clinical work, in our clinical laboratories, we actually need to look at DNA changes in the form specifically as chromosomes. So because in every body of every cell of our body, the genetic materials, DNA, is packaged into 46 chromosomes, so in 23 pairs. So one set of the chromosomes come from the dad and the other come from mom. And then so we typically need to kind of line them up. So many of you probably remember some kind of a study in a high school textbook that they're lined up chromosomes. We call it karyotype. So we have an image actually to show you. On the left side is a typical karyotype that you might have seen. So this is we try to identify normal versus abnormals. So in cancer, we're really trying to identify those cancer-related genomic abnormalities. So on the right-hand side of this slide is an example of an abnormal karyotype. So you can see different kinds of chromosome abnormalities. It could be extra chromosomes that's gained, even though it looks normal, or it could be entirely different chromosomes. And so it could be addition of a segment or deletion of a segment of a chromosome, or sometimes trading two segments of different chromosomes, trading places, etc. Yeah, so all these kind of things we try to identify, and that are very important for diagnosis and prognosis, like predicting the outcome and to guide what kind of best therapy to use. So yeah, so overall in our clinical laboratory, we need to look at these cells and then identify the abnormalities. And so that it actually requires very special training and in order to look at those different patterns. As Tom just pointed out, it's like extremely labor intensive. So actually, typically it takes days. And right now, usually it's almost like 5 working days to get a result. But for some diseases, when patients require immediate treatment and like acute myeloid leukemia, etc., really the sooner when we can get a result, the sooner the patient can get to the treatment.
And Min, can you tell us a little bit about what you're doing with Google? And when most people hear artificial intelligence, they start thinking, oh my gosh, is it going to eliminate jobs and do all the work of doctors and scientists? Tell us a little bit about what this process is and how it might actually enhance our ability to make diagnoses for patients.
Yeah, it's very exciting that we forged this collaboration with Google 4 years ago. And basically, we're trying to see, as I just mentioned, the process currently is very labor intensive and takes a long time. So our goal with Google is to see whether we can use artificial intelligence and machine learning to expedite this whole process. As you saw, it's pretty much white and gray grayscale images that we're looking at. And so in order to make the identification, in order to identify those abnormalities, we first need to, because usually this is the kind of cell that we see under the microscope, and there are hundreds to thousands of these under the microscope. So we typically will need to, first step is to align them into the karyotype images that I showed you previously. So aligning the chromosome itself takes a lot of time. It's painstaking and inefficient. And then also after alignment, the technologists also need to be using their specialized skills that are trained and to recognize the abnormalities. So because this boils down to pattern recognition, we think a artificial intelligence, machine learning model algorithm will be very effective in looking at finding these abnormalities. So we can take these, the images that we've had accumulated in the past, let's say 10, 20 years, so that we can feed into the various models of artificial intelligence models and to train those models and to see which ones would be the most effective in identify abnormalities. So yeah, so we worked with Google, and first we try to just look at how those models will be effective in align the normal and recognize normal chromosomes. And we're very pleased to say we've been able to choose a model that's able to align the normal chromosomes with 99.9% accuracy. And then many of the other people who are trying to use machine learning to do aberration detection failed. However, this model that we chose to use is really onto something wonderful. So we tested the detection of aberrations, chromosome aberrations in acute myeloid leukemias. And so far, we see this model that we've worked with is able to detect aberrations in greater than 98.5% of this situation. So it's really exciting, yeah.
And so, Min, one of the places where I think chromosomal analysis has been so critical, I mean, in many parts of medicine, but in one part is treating leukemia patients. When somebody comes in with leukemia and you want to find out what type of leukemia you're dealing with and what the right drugs to use are, it can sometimes take a long time. Do you think this is going to expedite our ability to treat leukemia patients faster when this gets more incorporated?
That's exactly the goal, because we're thinking, humans right now, we are only able to do so much. Typically, one case of such diagnosis takes a trained technologist 8 hours just to, line up and then looking at, because we need to analyze multiple cells. So these metaphases, we need to analyze 20 metaphases. And sometimes in a very complex setting, it'll be days before we can render a result. So using machine learning, we hope we can reduce this diagnostic time from days to minutes and seconds. That's exactly the goal, and it's very feasible, yeah.
So this next question is, right underneath me here at the Fred Hutch is a genomics facility that's absolutely fantastic, and we've got several Illumina sequencing machines that can sequence DNA at an incredibly fast rate, and we've seen great progress in something called whole genome sequencing. So my question to you, Minfeng, is will whole genome sequencing replace cytogenetics, or is there information you get from cytogenetics that you will never get from whole genome sequencing?
That's a wonderful question. In fact, using whole genome sequencing to replace conventional karyotype analysis in cytogenetics is our goal. We're trying to make ourselves lose our job in that regard. However, it's a long process. Yeah, these powerful new instruments for whole genome sequencing is going to give you lots of the base pair level information. However, how to assemble these complex, large data into meaningful kind of rendition of chromosomes and how they have abnormalities and how they're actually rearranged, etc. It's actually not simple. So it's based on the process of a very complex process of computational process using bioinformatics tools. And those tools are difficult because it's like assemble and things. And so right now it actually takes a very long time. And also it's not accurate. So with the, one of the goals that we're doing this using artificial intelligence for karyotype analysis is actually to provide a sort of a feed-forward loop. So we can use the information we get from the karyotype analysis to correlate with the whole genome sequencing results and see how we can best inform the bioinformatics tool to assemble the correct information, get the actually correct analysis in order to improve our way of doing whole genome sequencing, eventually to get most accurate information. And then, so this is actually a very effective way of doing it. And also, right now, there's many intermediate steps from karyotype to whole genome sequencing. As karyotype is still like the low resolution, but whole genome, single cell based kind of a technology. And a picture is worth 1,000 words. So looking at the picture, knowing exactly how different fragments traded places on the chromosomes, then compare them with the whole genome sequencing data, it's gonna provide very, very meaningful analysis tools.
And then what would you say the top cancers are now that we use cytogenetics in? What are the top cytogenetics cancers that we look at?
Yeah, mostly it's liquid cancer. Right now, we're applying the cytogenetics tools on, like acute myeloid leukemia, lymphoma, and multiple myeloma. In our center, definitely by far the most usage of cytogenetics analysis is leukemia, including acute and chronic, as well as multiple myeloma.
Excellent. And so, but it's harder with solid tumors. Is it because of the ability or inability to create metaphases? What makes solid tumor cytogenetics harder?
Yeah, that's a great question. So making cytogenetics from solid tumors like an art, because these cells from solid tumors, they do not want to proliferate in culture. Now, in order to get metaphase chromosomes, we're going to have to coax those cells into dividing, active division in culture. Because as we know, there's the cell cycle. So cells are not always in active division. So when cells are not actively dividing, the DNAs are like loose, the structure is loose, and they're more like a bowl of like tangled spaghetti noodles. But then when they're active dividing, these DNA will condense into the chromosome shapes that you're able to capture and into the chromosome that I showed you on those previous images. Yeah, so solid tumors, they do not want to divide in culture, so then it's very hard to capture those chromosomes when the cells are dividing. Whereas leukemic cells, and they are actually easier to get from bone marrow or blood, and then you're able to coax them into proliferation very easily. That's very easy.
And then one final question for you, which is, the place where cytogenetics has also made a big difference is in diagnosing congenital abnormality. And I know you're a cancer cytogenetics person, but you probably know a lot about congenital abnormalities as well. Does it still have a role in diagnosing Down syndrome and other types of congenital abnormalities that people need to diagnose?
Definitely. So the definitive diagnosis of genetic conditions still rely on these chromosome images. Yeah, so karyotype analysis is still the final answer. So even though there's a lot of the non-invasive methods of using just the blood to look at screening, using screening methods, but that's not the definitive way. It's still metaphase right now. Yeah. So even though karyotype analysis is a very mature technology for we've been using it in the clinic for over 60 years. It still has its advantages, and that's why it hasn't retired yet. But one day it will. We're working on the various ways and methods, and right now there's a lot of usage of it to help us also optimize and the newer technologies to make it usable and accurate and effective in diagnosing diseases.
Min, thank you so much. If I could ask you to stay here with us, and we will bring back from Greece, Dr. Petros Grybas, and from Montlake, Dr. Ramesh Rangan. Terrific. We've got the whole group back together. It's fantastic to have you all here. I guess I'm going to ask the first question to Petros and Ramesh, which is a lot of data has come out recently on the optimal therapy for early stage prostate cancer. And there was some data that shows that at 15 years for men with early stage lower risk cancers, that it looks like radiation therapy is similar for survival as surgery at 15 years, with excellent results for both, with more than, I think that number was 96% or 97% of men not having disease 15 years later with either surgery or radiation. Now, Ramesh, I know what side of the fence you're going to be on this. But I'd like to hear both of you talk a little bit about how men make that decision and what role radiation plays versus surgery in this setting. And Petros, maybe start with you, then go to Ramesh.
Thank you, Tom. Great question. It's an opportunity for me just to highlight, and Ramesh can comment, the value of the multidisciplinary prostate cancer clinic that we have every Thursday morning at Fred Hutch, UW. And we sit down again, radiation oncologists, urologists, medical oncologists, pathologists, radiologists, and we look at the patient, we look at the particular films, the CAT scans, the MRI, bone scan, we look at the pathology, and we try to make as much as possible a customized plan, a treatment plan, taking into account patient preferences and what we think is the right thing for the right patient at the right time. And sometimes there'll be more than one option, as you said. And sometimes the medical oncologist, may actually comment about systemic therapies. For example, if we use radiation therapy, we may also use a treatment we call hormone therapy to block the testosterone. So we talk about pros and cons of each option, and we're very excited because now we have clinical trials and we try to move the field forward. And we, as you quoted, the numbers and the percentages look much better now compared to many years ago. Ramesh?
And Ramesh?
Yeah, no, I couldn't have said it better myself. I think that, if you really believe in precision oncology, what that really provides the patient with is the power to choose. If you have a high cure rate like we do in prostate cancer for early stage prostate cancer, what we want to be able to do is provide our patients with options so that they can choose the best approach for them, and we help them and guide them. There's never a one size fits all, and that's true in prostate cancer as well. For some patients, surgery is the best route, absolutely, because the side effect profile with surgery is different than the side effect profile with radiation. For some patients, radiation is a much better fit for their lifestyle and where they are at that point in time. And to be able to do this in cancer more and more, when we get to the kind of cure rate that we're happy with, where we can say, okay, there are 3 or 4 different pathways, all with outstanding clinical outcomes, but you can choose which pathway best fits with your life. And I would say radiation now has earned a right to be at that table based upon some of the outcomes that Petros and you are talking about.
Yeah, because if you think about it, the average age that a man gets prostate cancer is generally older, tend to be in their 70s. And so if you look at a 15-year survival, that's pretty meaningful for men who are in their 70s. And so that's actually a terrific advance. Well, Dr. Rangan, unfortunately, not all the questions are about things that are positive. And this one is for you and for Dr. Fang. And that is the idea of radiation-induced malignancies, okay? And the participant says, can you share more about radiation-induced malignancies? And then Dr. Fang, I'm going to ask you to talk a little bit about treatment-induced leukemias that you see, and whether it's from radiation or whether it's from chemotherapy. We know those can cause leukemia, and our treatments, whether it's chemotherapy or radiation, they do have side effects, long-term side effects that can be important. And Ramesh, if you could talk about radiation-induced cancers first, and Min, maybe talk a little about some of the secondary leukemias you see through cytogenetics.
Absolutely. I think from the very beginning of utilizing radiation as a tool in the arsenal to treat cancer, we became aware of its power to potentially induce cancer in the healthy tissues of our patients. So that is at the forefront of our minds whenever we craft a treatment regimen for our patients. But it's important to contextualize this, which is that the greatest threat, the sad truth is the greatest health threat to the patient is the cancer that is within them at the time of diagnosis, not a subsequent cancer that may emerge decades down the road from the radiation exposure. Similarly, it's a reason why we send patients for CAT scans. Yes, there is a theoretical risk with any radiation exposure of a subsequent cancer forming, but the value we derive from that diagnostic information is far more important to the health of the patient at that moment than the low. And thankfully, with our better techniques with radiation delivery, both on the diagnostic side as well as the therapeutic side, the low, sometimes much less than 1% risk of potentially forming a second cancer somewhere down the road. So it is something that we are acutely aware of and we worry about, but it's something that we also have to help contextualize in the full spectrum of care for our patients.
And Min, how about secondary malignancies in the bone marrow when you do karyotypes?
Yes, so we definitely see a substantial portion of our patients, their leukemia or pre-leukemia conditions arise from being exposed to chemotherapy or radiation therapy previously. Therefore, they develop these kind of secondary cancers, secondary, like especially leukemia. Yeah. So these secondary malignancies, they have specific features of chromosome abnormalities typically, and they tend to do poorly overall in terms of overall survival and relapse. So it's not, like you said, it's not always a good picture. However, our goal is, again, I, as a behind-the-scene doctor, I primarily deal with these specimens that we receive from the patients and try to get the accurate diagnosis so to be applied. That's part of the precision medicine, so that we can give the oncologist the information and the radiation oncologists as well, so they can treat properly. Now, one subset of such kind of secondary cancers actually develop because they have certain inheritable genetic predispositions. So that's a very small portion of patients, but there will be patients like that. They're born with a certain gene mutation. For example, TP53 gene that has a genetic condition called Li-Fraumeni syndrome. So then these patients, they naturally already are predisposed to develop cancer more often than the others. And then when they're exposed to radiation, etc., that basically kind of exacerbates the situation. And so they can develop secondary cancers or more additional primary cancers, etc. So these are all the kinds of things that we search in our diagnostic testing, and to look at whether the patient has predisposition syndromes or whether they have a purely kind of somatic, so-called body cell only genetic mutation, DNA change that we can just treat relatively easily. Yeah, so these are all very complex issues.
Terrific, thank you, Min. So Petros, this is a good question that's come in, and I know you're a hero and a huge believer in immunotherapy. You're one of the true leaders in this area. But someone points out, what limits the use of immunotherapies, and can it be used for all cancers, both solid tumors and blood cancers?
Great question, Tom. Everything in life has pros and cons, and our job as providers, caregivers, to take care of the patient and balance carefully the benefits and risks. So in each individual scenario therapy setting, we want to see whether the chance of benefit with immunotherapy outweighs the risks. And what are those risks? We call them immune-related adverse events, so IRAEs. And actually, we have a significant focus here in our program. We have established a program in the last 5 years evaluating these side effects of immunotherapy. And the way it works is when the immune system gets activated and aggravated against cancer cells, there is a chance that maybe in a small proportion of patients, this immune system may start attacking our own body, like the thyroid gland, or the skin, or the gut, or the lungs. And that's why we monitor our patients very closely and carefully. Most of those side effects, Tom, are usually managed relatively easily, but in a small proportion of patients, it requires what we call steroids to suppress the immune system because it went overboard. So we have to be cautious about those potential side effects. And we have actually a program here. We have a tumor board where we discuss challenging cases with such side effects. We have an educational series inviting speakers, experts in different parts, educating our team about those side effects. And we do research, trying to do some work collecting blood and looking at biomarkers, Tom, in the blood to try to predict who is going to be the patient who's going to develop this side effect. How can we prevent that in the future? That's part of our active research right now.
Excellent. So this next question is for Dr. Rengen. And Ramesh, we don't have the benefit of having our colleague, Dr. Doug Wood, on the call with us right now, who's the chair of surgery and who's a lung cancer surgeon. But, and it's funny, I would have answered this question very differently now than we would have answered this question 7 years ago. which is if you have a tumor in the lung that can be reached easily by surgery, is there a role for radiation now? And can some of the new radiation techniques, stereotactic body radiotherapy, can they produce results that are as good as you can get with surgery? And where does that stand right now? Great question from one of our callers.
Yeah, outstanding question, and I promised that caller that my check is in the mail and I'm good for it. And what I would say is there has been this is one of the most exciting areas of evolution in our field, which is as Dr. Lynch said, for the better part of the last century, the answer on the test, if you have a tumor in the lung, is to find a way to operate and get it out. And we have actually evolved our techniques in radiation imaging techniques, so we understand with high resolution how the tumor is moving when the patient is breathing in and out, so that we can have the beam follow the tumor, and how we can be ultra precise with our delivery, so we can deliver very high dose with specificity to the tumor, such that our outcomes are very comparable to surgery. So much so that 3 separate randomized trials were launched comparing surgery with radiation, with stereotactic body radiation, or SBRT, in this setting. Now, these trials didn't conclude, none of them completely finished, and the reason is very hard to find a patient who is agnostic, meaning we'll leave it up to a coin flip as to whether they undergo surgery or they get radiation treatment. Patients have a right to make a choice there, and it's very hard for patients to be willing to leave that up to a coin. And so as a result, these trials didn't accrue very well, but a pooled analysis of these trials were published in one of the preeminent journals in our field, in the Lancet Oncology, that showed that very similar outcomes. So what's different about radiation versus surgery? Well, the real forward-thinking, next generation excitement here is we leave the tumor behind, but it's not the same. When we hit the tumor with stereotactic radiation, that tumor dies, but in some patients, it can behave as an indwelling vaccine against the rest of the cancer. And so what we can do is trigger a favorable anti-cancer immune response in that patient. You hear Dr. Grivos talk about the value of adding immunotherapy after completing surgery and chemo and radiation for bladder cancer. Well, if we hit the cancer with stereotactic body radiation, the biggest risk to that patient is not the cancer coming back where we treated, but the cancer coming back elsewhere. And if we are able to create a vaccine from that cancer itself to protect the patient, then that may actually lead to improved outcomes than even, I dare say, than a surgeon can offer you from their scalpel.
But Dr. Wood is not with us, and we are going to give him the next word next time. So I guess the same question I want to ask all 3 of you.
And I'm taking full advantage of that.
You're taking full advantage of it. We have a great group of people participating, and the people who are on the call, many of them have given generously to support research at the University of Washington and at the Fred Hutch. So I guess the question I have for the 3 of you is, you guys all are smart. You all have grants. The Hutch has terrific resources, as does the University of Washington. Why do we still need funding to help research? And how does funding help research? And I'll give the first word to Ramesh, since he's a department chair, and then Petros and Min can follow on and talk about how funding helps your research and makes it work. Ramesh.
So there's never any end of the creativity of our faculty. We've had the good fortune of assembling some of the greatest talented minds in terms of engaging in cancer research in the world, both at the Hutch and at UW Medicine. And these ideas, if we only rely upon the National Cancer Institute and other funding agencies to support bringing these ideas from the bench to the bedside, we are going to really slow the pace of progress in cancer research. That's why donors and people who are willing to give play such a critical role. I think I would say that UW Medicine and the Hutch probably could not exist without philanthropic support. Cancer research could not move forward without philanthropic research. It is a misperception to believe that government funding or private funding on its own can propel cancer research forward. There is no way for that to actually, for us to fulfill our promise. So that's why you're so important.
Thank you. Min?
Yes. So definitely. I mean, research is not short of ideas, and then also for like the specific type of research that I do is very much translational in nature. So oftentimes, whatever you can bring into the clinic for a diagnostic tool, even though, like for example, genome sequencing, it's already a whole genome sequencing that's already out there. However, it's not quite ready for prime time to the clinical usage, because the principle is like do no harm for patients. And so when we bring any new novel technology, cutting edge technology into the clinic, there's extensive validations and translation work that needs to do to ensure the highest accuracy and ability to detect these abnormalities and using the technology without any harm. So this process by itself may not be novel, so therefore sometimes not quite funded by like the National Cancer Institute or traditional grant agencies. So, but this, nevertheless, it's a critical process. Otherwise, there is a significant delay in applying the cutting edge technology to the clinic for patients' benefit. So that's kind of part of the reason when I first had this idea of doing artificial intelligence for karyotype analysis, I had to approach this industry. And then, but industry, the Google also has layoffs and things. And so we're actually having reduced funding in that regard as well. So yeah, your generous donation has been extremely helpful.
Hugely important. And the last word from the gentleman who's in the birthplace of democracy right now, Petros.
I cannot agree more and cannot emphasize enough with what Ramesh and Min said. It's so vital and of paramount importance to have the wonderful and generous support of philanthropists and donors. They move the field forward. Because of you, we're making progress, and there are many examples. I know we're running out of time, but let me just in 1 minute outline 3 examples. For it. Number one, sometimes to get a big grant, we need some pilot funding to show that we can do the work, what we call pilot funding. And this pilot funding is so critical, so important. Without it, we cannot secure the grant funding from the government, from state, for foundations. So it's critical to have this starting point, this fuel in our engine to make the work done and so that we can fulfill this promise. Number 2, we need infrastructure. I can share with you very quickly, we're thrilled to have patients who really find purpose and meaning as they want to, so allow us to do a research autopsy, which is so important because we learn more and more about why this cancer behaves so aggressively. How can we do biopsies in different areas of the body to learn more about that? And this infrastructure requires philanthropic support. And the last thing, Tom, before we go, after clinic last week, I went to my good friend, Dr. Andrew Shea. He's a brilliant scientist at the Hutch. We sat down and we talked about his wonderful work in the lab that was published in Cancer Cell 2 weeks ago, how to translate this fantastic work into a clinical trial. And it's not as easy as we all know, and we need philanthropy support to translate these discoveries in the lab and transform the treatment landscape. So these are just examples of how philanthropy can make a huge difference globally. Thank you.
Wonderful. Thank you all very much for participating. Thank you all for listening. One key thing to remind everyone, this year, Obliteride is August 12th. Please sign up. It's the biggest event of the year for us here at the Fred Hutch in terms of community engagement. You can bike, you can walk, you can volunteer. Fantastic event. And this year, you can direct your funds to breast cancer or bladder cancer or radiation or cytogenetics or whatever you're interested in. Again, thank you all for being together, and look for more and register at obliteride.org. Thanks so much. Bye-bye.